Welcome to the CVI 2020 Operators Enclave, where we bring you chronicled cases from the cath labs around the country demonstrating skills and techniques that everyday interventionalists would find very useful. Now, this case coming from our laboratories in the VA North Texas healthcare system and UT Southwestern in Dallas, Texas, exemplifies an everyday challenge that we face in the cath labs during managing patients with advanced coronary artery disease and peripheral artery disease. This is a story of a 72-year-old diabetic veteran who was admitted with a progressive increase in shortness of breath and elevated cardiac enzymes, all consistent with a non-ST segment elevation myocardial infarction. His past medical history was significant for diabetes mellitus and a history of peripheral artery disease. He had undergone a right-sided femoral tibial artery bypass in 2012. His physical examination was significant for bilateral scattered rales over both lung fields, a soft systolic murmur, and a heavily scarred right groin area with diminished pulses over bilateral common femoral arteries. There were no palpable pulses over the pedal arteries. His ECG was significant for sinus tachycardia and pretty dramatic anterolateral ST depressions, and the patient was referred promptly to the cardiac catheterization after initial medical management. As you can see on the diagnostic angiogram of the left coronary artery, there is diffuse disease in the short left main, which was called severely diffusely diseased. The circumflex has heavy calcification and 80% stenosis in the mid segment and the bifurcation of the obtuse marginal and the native circumflex branches. The proximal LAD is of good caliber, has some moderate amount of calcification, and the mid and distal LAD segments are diffusely diseased. The right coronary artery is small caliber, diffusely diseased, and therefore the PCI of the left main LAD and circumflex was contemplated as the patient was turned down for coronary artery bypass surgery. Overall LV systolic function was estimated at 35 to 40%. There were multiple wall motion abnormalities as shown on the parasternal long and in the short axis views. The inferior wall is hypoareokinetic, as is the lateral wall. The septum is hypokinetic, only some parts of the mid and distal anterior walls were contractile. There also was moderate mitral regurgitation that is not shown here in the video clips. An aortogram was performed from the left radial axis first. As you can see, there is evidence of extensive amount of calcification in the distal aorta at the common and iliac and common femoral artery locations of both limbs. You can also see stents present in the right common and external iliac locations. There is also evidence of extensive amount of nodular calcified granules in the external iliac extending into the left common femoral arteries. There is also evidence of a bypass graft that is attached on the right side from the common femoral artery to the anterior tibial arteries. The left common femoral artery that was extensively calcified was initially pre-dilated with a conventional balloon 5 millimeter and then with a 6 millimeter shockwave balloon. The common femoral artery and some segments of the external iliac artery on the left side were dilated. The final result after shockwave dilation is shown in the right panel. Given the suboptimal result of the left common femoral and distal portions of the left external iliac arteries after shockwave treatment, although the lesions were dilated, a Viabahn stent insertion was planned. As you can see on the panel to your left, the Viabahn stent implantation and deployment. And the final result after a Viabahn stent placement is shown in the right panel. Just want to let you know that the stent was extended all the way to the internal iliac takeoff or just past that. The patient was brought back for his coronary PCI with impella support, and the impella support was planned from the left common femoral artery. Prior to that, access to the right common femoral artery was obtained. As you can see on the screen in the right panel, the takeoff of the right fem to AT graft is seen, and the distal edge of the stent on the right side external iliac is also shown by the yellow arrows, and the distance between them is the area that is probably the best site for a vascular access stick. However, closure of that area either with perclose or with angioseal or other devices could grab at the origin or distort or disturb the origin and flow into the graft. And therefore, we actually made a decision to stick through the stent that was slightly at the top of the femoral head. Shown here are two panels displaying the access into the left common femoral artery Viabahn stent with a micropuncture needle. As you can see that distortion of the stent is minimal, and this is 3 days after his Viabahn stent implantation. There are other techniques that we can discuss later to prevent collapse of the Viabahn stent after a fresh implantation and vascular access. The micropuncture wire on the right panel is advanced freely, and access is obtained and confirmed with an angiogram. PCI, as I stated earlier, was performed through a 7 French sheath that was inserted through the impella sheath, and it was obtained through a micropuncture access through the right upper quadrant of the impella sheath, and then placement of a guide wire and placement of a 7 French sheath for PCI, period. Now, this raises an important question: why the right common femoral artery was punctured through the stent? And that was necessary in our minds to perform the puncture of the left under angiographic guidance, number one, and number two, that if there was any deformation or collapse of the Viabahn stent or loss of flow in the left common femoral artery or to the left rofunda, then an intervention could be performed through the right common femoral artery access. Here you see the angiogram through the micropuncture access sheath through the Viabahn stent in the left common femoral artery, followed by pre-closure. As we are going to deploy an impella through this, we deployed 2 perclose pre-closure sutures to retain and close the vascular access after the impella is withdrawn. In this case, predilation of the vascular access in the left common femoral artery is performed using sequential 8, 10, and the impella sheath dilator for the 2.5 impella, that is the 12 French sheath, and you see the successful dilation and followed by impella sheath insertion successfully achieved. After placement of a 2.5 impella in the left ventricle, a 7 French XB 3.5 guide is advanced through the same impella sheath. The circumflex is crossed with a run-through wire and then exchanged to a rotafloppy, and then a 1.25 millimeter burr is used to advance into the circumflex and obtuse marginal branch, and rotational atherectomy is successfully performed, followed by balloon dilation and stenting as shown in the subsequent images. 2 stents in the obtuse marginal branch and circumflex main branch were placed. As you can see, the first stent after predilations of both lesions was placed in the distal circumflex and was positioned with a balloon in the obtuse marginal branch. After deployment, the stent was post-dilated and a 3.0 times 38 millimeter stent was placed in the obtuse marginal branch, and then bifurcation kissing balloon angioplasty was performed. The final result of the circumflex and obtuse marginal branch interventions is on the next slide. This is the final result, as stated earlier, of the circumflex and obtuse marginal branch intervention. Now, please note the extensive amount of calcification, the performance of atherectomy, bifurcation stenting, and very aggressive post-dilation with non-compliant balloons was performed as high as 3.5 millimeters in diameter. Non-compliant balloons were used for post-dilation here. Following PCI of the circumflex, PCI of the left main and LAD was performed with a 4.2 millimeter stent. The stent positioning angiograms are shown here, followed by the final angiograms in the next slide. The final result for the left main PCI are shown in the RAO and in the LAO caudal projections on this slide. The stent was post-dilated with a 4.0 millimeter NC balloon and then confirmed with IVUS. Balloon angioplasty of the vein graft to the anterior tibial artery was performed to restore perfusion to the right lower extremity, as the patency of such grafts is important to restore in a timely fashion, as once they occlude, recanalization becomes quite challenging. The final result is shown on the right side of the panel. Given the high stick in the right common femoral artery, a 7 by 60 millimeter balloon was placed in the common femoral artery on the right side, and the sheath was removed, and a follow-up angiogram was taken after balloon was deflated after 5 minutes. The panel onto the right shows the angiographic images after the balloon was deflated, and as you can see, there is a area of intrapelvic bleed right at the juncture of the right external iliac and the transition into the common femoral artery. The area of the perforation in the right external iliac artery was promptly sealed with a 7 by 100 millimeter Vivan stent deployed over an 018 wire. The panel onto the right shows the final angiogram after a post-dilation of the balloon and treatment of the proximal segment of the right fem-tib graft. And the final angiogram is shown here. The case details are shown here. 177 cc's of Visivic contrast was used during this case, and the post-procedure LVEDP was 14, which we were very pleased with. The patient actually did extremely well and was discharged on day 2 after the procedure with no complication and with excellent healing of bilateral common femoral arterial access sites. This case exemplifies the types of patients we encounter in our cath labs every day. These patients have advanced coronary and peripheral artery disease, and successful and safe execution of coronary interventions requires a thorough and rigorous understanding and knowledge of endovascular and coronary devices, especially device profiles, device deployment techniques, and last but not least, careful review of pre-procedure angiograms and rigorous planning before embarking on these cases. Thank you.